Hello, my name is Saul Wiener, and this is the fourth in a series of videos on the topic of contextualizing care. The first couple of videos looked at what we mean by patient life context and contextual error, and introduced a four-step approach to contextualizing care. The third video examined the research that underpins this body of work. In this video, we asked the question, what can we do to help clinicians get better at contextualizing care, to make fewer contextual errors? We examined three opportunities to intervene at the level of medical education, quality improvement, and through the use of technology. Like the previous video, this one is also grounded in research evidence, but also like the previous video, we had to cover a lot of ground in not much time. So I've provided references for those of you who would like to look at the original research in a little bit more depth. So thank you for your interest, and let's get started. Before we start looking at ways to prevent contextual error, let's just quickly revisit the definition, which has been discussed in prior videos in more detail. So, a contextual error is a care plan that is inappropriate because of a failure to consider patient life context. Operationally, it is caused by a failure by the clinician to address a contextual factor in the care plan. Again, as a reminder, looking back at a case that we discussed earlier, let's look at how contextual errors occur. Specifically, where is the communication breakdown? So in this case, a patient is on an expensive inhaler and has lost control of their asthma. During the visit, the patient says, "Boy, it's been tough since I lost my job." And the provider neglects to ask, "How has it been tough since you lost your job?" We would call that a failure to probe. The patient nevertheless goes on to say that he's having trouble paying for his asthma inhaler. Despite the patient stating up front what they're struggling with, the clinician still drops the ball and just doesn't respond. This would be a missed opportunity to discuss affordable alternatives. So we see here how a failure to probe or a failure to address a contextual factor in a care plan after a patient has revealed what the contextual factor is, we see how either of those results in a contextual error. So we've looked at three opportunities to intervene. The first at the level of medical education. We've done studies both with undergraduates, meaning medical students here, and also with graduates at the residency level. The second is through a quality improvement intervention, specifically an intervention to improve the performance, the clinical performance of clinicians. We've studied an intervention that is multidisciplinary and that utilizes the general methodology of audit and feedback, in which data is collected episodically on the performance of clinicians, and then that data is used to give them feedback. In our work, we've included attendings, residents, nurses, clinical pharmacists, and even front desk clerical staff. And then finally, we've done a study on the effectiveness of clinical decision support. Those are tools in the electronic medical record to see whether we can help clinicians do a better job of both being aware when there are contextual factors and then attending to them in their care plan. That last study is still ongoing, but I'll describe it briefly. One of the first intervention studies we did involved designing a weekly case-based session for medical students during their internal medicine sub-internship. This was a randomized controlled trial, and we assessed the students against a control group utilizing standardized patients. The intervention involved students getting together in small groups with a facilitator to talk about patients they had recently admitted to the inpatient service, and in many cases to actually go back to the bedside and revisit the history that they had taken to see if there were contextual issues that they might have overlooked that would ultimately change the way they would plan the patient's care. This approach was not only case-based, but gave learners an opportunity to have a kind of aha moment where they could see that the original approach had been so biomedically focused that in many cases it overlooked essential patient life context. The intervention turned out to be effective, at least based on the way we had evaluated these students using standardized patients. And I'm going to talk about why I'm qualifying that in just a moment. In the second intervention, we took a very similar approach, this time with medical residents. And the main difference was that instead of evaluating them utilizing standardized patients, we invited real patients to record their visits incognito with these residents. And the difference here, of course, is that with standardized patients, the learner knows that they're being assessed. They even know often what they're being assessed at, And in the second, they have no idea when they're being assessed, and you get a snapshot of care as it's actually practiced. And in this latter study, the intervention turned out not to be effective. So as you probably can see where I'm going, this was not so much that the intervention, quote, worked in one case and then, quote, failed in the other. It's that in the latter, we were measuring what clinicians actually do in practice. In the former, we were measuring what they do when they know they're being assessed. And this is what we've referred to and others have referred to as the skills to performance gap. It's one thing to teach learners to do something and show that they have learned it when they know they're being tested, but it's quite another to change what they actually do when they're not really thinking about it and they're not aware that anybody's looking. So overall, what we learned from these two studies is that while you can teach skills of contextualizing care fairly quickly, it doesn't really have the intended effect, which is to change practice. To do that would surely require something much more substantial than a few case-based sessions. Now, I suspect, and this is just my opinion, that an effective intervention would probably have to start at the beginning of medical training. Imagine a curriculum in which medical students are introduced to patient life context at the same point that they're introduced to clinical reasoning at the very beginning of case-based learning. So, for instance, if you're in a class where you're learning basic pharmacology, and the question is, what's the right drug for this bug for a particular infection? The follow-up question might be, okay, so now what are you going to do about it if the patient can't afford that medication? What's your approach? And you can see that this teaching strategy, which is intended to really mirror real-life practice, would essentially embed context into every clinical-based learning opportunity, starting in the preclinical period of a medical student's medical education. The area perhaps where we've done the most work on interventions is at the level of quality improvement. In particular, we focused for many years on an approach in which patients volunteer to carry encrypted audio recorders into their visits. And I've talked in a prior video about how we've used this approach to do basic science research on contextualization of care. The difference here is that instead of simply analyzing these audio recordings for contextualization of care and contextual error using our 4C coding method, here we share what we learn with the clinicians who are participating so that they can actually learn from both the best examples of contextualized care and the missed opportunities where we see contextual error. As you can imagine, a quality improvement program in which patients are audio recording their visits, often covertly, is likely to alarm a number of providers. And so we've learned that to make this program palatable and even welcome, we have to follow some basic principles, and there are actually three that we've adopted that I'll share with you here briefly. The first is that the program must not feel threatening, particularly to clinicians who are often skeptical of being audio recorded by patients. So we've adopted a protocol in which the audio recorders are, of course, encrypted. They're collected, as I mentioned in the prior video, by a project assistant or volunteer who uploads them to a secure server. They're only accessible to a small group of trained audio coders who are not clinicians. Identifiers of patients and clinicians are removed immediately. The data is only shared in aggregate. Physicians can actually get individual feedback if they request it, but the default is that it is grouped. The second is that the protocol must not feel burdensome. There can't be any additional work. We recruit a clinical champion at each site where we do this. So that's going to be a physician who is a peer to the physicians who are participating. That individual will share the data. We generally provide them with PowerPoint slides with each case on a slide. They share that data with their peers at standing meetings. And I think the fact that the person sharing the data is a peer also contributes to making the project feel less threatening. And then finally, we want this program to feel worthwhile. We make sure that clinicians not only value the data itself, but we have an arrangement with the American Board of Internal Medicine and the American Board of Family Medicine where they get maintenance of certification credit towards their board recertification, and they also get continuing education credit for participating. And then the key element here is that we share the results not just once, but on a recurring basis, and we do it in multiple ways. We give them examples of where they're either successful or unsuccessful at picking up on contextual red flags and factors and at contextualizing the care plan. And we also share the data in multiple ways, often graphically. So for instance, here you see what's happened at a particular clinic where we've been giving physicians and other clinicians feedback over time. So the blue line represents the percentage of contextual factors addressed in care plans from audio recordings collected during the specified time period. The yellow line represents the percentage of red flags probed on the same audio recordings. And along the bottom, you can see that physicians have been receiving feedback at various points in time. POC stands for plan of care. So, for instance, from June 6th to November 9th of 2017, 37 out of 69 contextual factors, that's 54% of contextual factors, were addressed in the care plan. Although not all of our graphs are this upward sloping, what you can see here is that over time, these physicians got better and better at contextualizing care. We don't always see such success, but as I'll be sharing with you, on average, we do see that with feedback, physicians and other healthcare professionals get better. What this figure shows you is that when we aggregate the data, we get a snapshot of what patients in a particular clinic are struggling with. In this particular clinic, we can see that based on the 4C coding of audio recordings, a number of patients were struggling with access to care issues. Others were struggling with deficits in skills and abilities. And then you can see a smattering in several other areas. And these 12 categories harken back to one of the prior videos where I showed you the 12 domains of patient life context. We've done one large study of our quality improvement program across 6 ambulatory sites within the Department of Veterans Affairs. Patients volunteered to audio record over 4,400 encounters with 666 providers. 67% of the audio recordings contained at least one contextual red flag. 55% of those red flags were probed, and 57% of the probes uncovered a contextual factor. 67% of care plans were contextualized prior to feedback and 72 post-feedback, a significant improvement. We saw good outcomes in 46% of non-contextualized care plans and in 73% of contextualized care plans, which was a significant difference. Perhaps most remarkably, we saw a small decrease in hospitalization rates among the patients of physicians who participated in this QI program, from 19% to 16.5% before and after they'd received feedback. Approximately 987 hospitalizations were avoided at a cost savings of $25.2 million. Since the cost of the intervention was just over $330,000, this was a remarkable return on investment. I should also mention that this study was designed with a control. We used a methodology in implementation science called stepped wedge design. And for those of you who are interested, I've provided the reference below. And finally, we're conducting a clinical decision support randomized control trial. Clinical decision support provides timely information, usually at the point of care, to help inform decisions about a patient's care. CDS tools and systems help clinical teams by taking over some routine tasks, warning of potential problems, or providing suggestions for the clinical team and patient to consider. Most of the research on CDS and most of the utilization of CDS has been biomedically focused. We decided to see what would happen if we adopted this technology to help clinicians contextualize care. The basic design of our intervention had 2 components. First, we wanted patients to be able to complete a questionnaire in which they would have an opportunity to tell their clinicians what they were struggling with in terms of any contextual factors. We did this by embedding a questionnaire in the patient portal. That's the part of the electronic record that a patient can access. In the pilot we designed, they can actually go into that portal, complete a questionnaire, and anything that's positive, if they say they're struggling with a transportation issue or an inability to afford a medication or whatever it is, that data will then appear in the template of the physician's note at the start of the visit. So the physician will open their note and they'll see that the patient is trying to tell them something. We actually create a contextual care box that says something like, your patient wants you to know that they can't afford this, they don't have transportation to that, and so on and so forth. The second component is that the electronic health record itself looks internally for some key contextual red flags, like the patient has been missing appointments, or they've not been refilling meds, or they've gone to the emergency room a lot. We've actually identified 7 major contextual red flags that you can mine directly from the electronic health record. The EHR mines that data, and again, if any of those are above a certain threshold, that information will appear in the template, in the contextual care box, so that when the physician sits down with the patient, they'll see information provided to them directly by the patient and also by the EHR about contextual issues that they should be thinking about and exploring further. And then finally, we also built into this trial software that would pre-write orders where there were likely orders that would assist the patient. So for instance, if the patient was confused about their medication, there would be an order for a pill box. If the patient needed help with paying for medication, that would trigger a referral to our indigent care office. And again, these would be orders that would be pre-written for the physician. The physician wouldn't necessarily have to accept them, but if they just clicked OK, those orders would be activated. And then to make it even easier for the physician, as soon as they've taken an action, text will appear in their note so that they don't even have to type what they did. We've designed this study around 2 widely used electronic health records, and we've conducted it at 2 institutions that are quite different. We're now in the final stages of looking at whether this intervention is effective. So in summary, there appear to be 3 ways in which you can address the problem of contextual error. The first is medical education, and as I said, it holds promise, but quick fixes won't be sufficient. It's not going to be as simple as a workshop or a single sub-internship or something along those lines. If you take that approach, you can certainly improve clinicians' skill, but you're not likely to change what they actually do in practice. The second is actually quite effective. However, it does require audio recording visits. Now, when I present this approach, I often meet some skepticism. People will say, well, I'm glad that it worked when you did the study, but this doesn't really seem scalable. I'd like to push back a little on that. First of all, because we're inviting patients to audio record their visits and they're going into those visits anyway, the costs of doing this work are really not that substantial. The major effort is the time and expertise that it takes to code the audios. But it doesn't take a lot of audios to provide physicians with valuable feedback. And as I showed in the study that we discussed in some detail, there is a tremendous return on investment. Also, we're experimenting with even simpler models for collecting the audio recordings. For example, we're working with a virtual scribe company, which audio records visits anyway, so that their virtual scribes can write notes for physicians. And we're seeing if coding directly off of those audios is an effective way of generating feedback for participating physicians. If it is, then this intervention will be even more scalable. And finally, we don't have final results yet on clinical decision support. I will say that the preliminary results do look encouraging. And if this turns out to be a viable intervention, this is, of course, going to be quite straightforward to scale because it can be built into the features of many existing electronic health records. So that completes a quick overview of the work that we've been doing to address the challenge of helping clinicians get better at contextualizing care. Thanks, as always, for your interest.